Imagine a behavior analyst who is like absolutely brilliant with data. I mean, their graphs are flawless, their operational definitions are tight.
Right, the perfect practitioner on paper.
Exactly. But when you look really closely at their caseload, a very quiet, very disturbing pattern sort of emerges.
Yeah.
The lower income families at their clinic are receiving something like 40% less parent training time than the wealthier families.
Wow.
And here is the truly uncomfortable part. The behavior analyst isn't doing this maliciously. They actually think they're just being, efficient with their clinical
Which
hours.
is terrifying, really.
It is. So, welcome to today's deep dive. We are thrilled you are joining us. Today, we are turning the scientific method around and pointing it at the scariest, most unpredictable instrument in the entire field of applied behavior analysis.
Yep, your own brain.
Exactly. Oh, and real quick, if you want to access study guides, tools, and ABA resources related to all this, check out the link in the description to our Stan store. It's a lifesaver.
It really is.
Yeah.
And, pointing the lens at ourselves is a profound shift in perspective. Our mission today is to tackle BCBA Foundation's E11, which focuses entirely on identifying and managing personal bias in practice.
Right.
To do this, we are synthesizing a very specific stack of sources. We have a comprehensive mix of BCBA mock exams, the ethics code for behavior analysts, and some incredibly detailed ethical scenario workbooks.
And those workbooks show us exactly what happens when practitioners lose their objectivity.
They really do. It's eye-opening.
And whether you are currently prepping for the BCBA exam and need to understand how the board tests this, or you're a seasoned practitioner trying to audit your own clinical decision-making, this is vital.
Absolutely vital.
Because understanding how our own hidden lenses warp our interventions isn't just theory. It directly alters the dosage and quality of the care you provide. Okay, let's unpack this. Because the first thing we have to confront is what the Behavior Analyst Certification Board actually expects from us when it comes to our own private internal biases.
And that expectation is codified primarily in Ethics Code 1.7. That one is titled Awareness of Personal Biases and Challenges.
Right.
What is critical for you to understand right out of the gate is how the board views the very existence of bias in a practitioner.
Which brings us to a massive misconception. If you are studying for the exam, you really need to listen closely here. There is a classic trap that trips up test takers constantly.
Oh yeah, the Wizard Prep materials highlight this perfectly with question 19.
Yes. The question asks what most closely aligns with the BACB's philosophy regarding personal biases. And the trap answers, the ones that sound really, really professional, are that behavior analysts, quote, are not to have biases.
Or that they must completely remove any bias or challenge they have.
Right. And I mean, those trap answers sound like the ideal, don't they? The objective, blank slate scientist.
They do sound great, but the BACB's philosophy relies on actual behavioral science. To claim you have zero bias, or you can permanently delete a bias from your brain, is to deny the very principles of behaviorism. You are a human organism with a learning history. You have been shaped by your environment, your upbringing, your culture, just like the clients you serve. You can't just erase that.
Wait, hold on, though. I have to push back on this a little bit.
Sure.
If the BACB says we can't erase our biases, and the correct answer is just that we must know our biases and document our efforts to mitigate them, isn't that just a get-out-of-jail-free card?
How so?
Yes, Your Honor, I provided substandard care to this demographic, but I documented my prejudice in a journal, so I'm totally ethical. Where is the actual line between just being aware and actively preventing harm?
Well, this raises an important question, and it is exactly why the code doesn't stop at mere awareness. The ethical requirement is really a three-part contingency.
Okay.
You must know the bias, you must actively ensure it does not impact your professional work, and you must document the mitigating steps you took.
Ah, the mitigating steps.
Right. The documentation isn't a diary entry about your feelings. It's a structural clinical barrier.
That makes a lot more sense. If we
Yeah.
think about it mechanically, it is like driving a car, right? Every single car on the road has a blind spot.
Oh, that's a great way to look at it.
Yeah, it's a structural inevitability of how the vehicle is built. You cannot physically remove the blind spot from the car. But if you just pretend it doesn't exist, you are going to merge into another vehicle and cause a massive crash.
Right, you'll do real damage.
So what do? You install side mirrors. You physically turn your head to check your shoulders. And in the context of ABA, your mirrors are your permanent products.
Yeah.
They are your peer-reviewed data, your inter-observer agreement checks, your procedural fidelity checklists. They are the external tools that let you see what your brain naturally props out.
That is a perfect translation of the concept. The ethical mandate isn't to be a flawless, unbiased machine. It is to possess the clinical humility to identify where your blind spots are and to permanently install those mirrors.
Yeah.
You document the safety checks to prove professional accountability.
But we know that having the mirrors installed doesn't mean people actually look at them.
Very true.
So let's explore how these blind spots actually sneak into clinical practice and warp our treatment plans. Because the scary part isn't the bias itself, it's how our brains disguise that bias as clinical preference or efficiency.
Exactly. Our sources provide a brilliant example of this disguise in the Cooper text. The text points out how a practitioner's personal history might cause them to inappropriately favor one intervention method over another.
Oh, right.
Specifically, it mentions a scenario where a behavior analyst might consistently favor a differential reinforcement procedure over a punishment procedure.
And on the surface, you might think, well, prioritizing reinforcement is literally in the ethics code. That's just good practice.
It is good practice until you analyze the actual functional mechanism driving the behavior analyst's choice.
Right.
If you are choosing differential reinforcement simply because your personal history makes you deeply uncomfortable with punishment, even in a severe, dangerous case where the scientific evidence, the literature, and the specific urgent needs of the client point to a different approach, then your personal bias is dictating the treatment, not the data.
Here's where it gets really interesting if we look at this through a functional lens. The practitioner in that scenario is actually engaging in escape behavior.
Oh, absolutely.
Their history with punishment, maybe they saw it implemented poorly, maybe it triggers anxiety, serves as a motivating operation. So when they face a severe target behavior, choosing differential reinforcement allows them to avoid their own internal discomfort.
Yeah.
The practitioner's clinical decision-making is being negatively reinforced by their own emotional regulation. They aren't accessing a reinforcer for the client. They are escaping an aversive for themselves.
What's fascinating here is how seamlessly we can functionalize our own professional failings. And when we do, we see how dangerous it becomes.
Yeah, it's insidious.
You are letting your own comfort zone override objective assessment results. But the sources also show us examples where the behavior doesn't look like a gentle preference for reinforcement.
Right.
Sometimes it is directly, measurably discriminatory. Let's look at the scenario you mentioned at the very beginning of the show. This is Case 14 from the Ethical Scenario Workbook titled Discrimination Discrepancy.
Yes, the case of Landon. So Joni is a clinic director conducting routine audits of her BCBAs. She pulls the caseload data for Landon and discovers a glaring discrepancy.
A huge red flag.
Exactly. Landon is providing significantly fewer parent training hours to his lower income families compared to his families from a higher socioeconomic status.
And when Joni confronts him, Landon's justification is a textbook example of unchecked bias.
It's so bad.
He tells his director that it seems like a waste of time to offer parent training to these lower income families because they are, quote, always working, just sitting around, or not interested.
I mean, he didn't take baseline data on parent engagement. He didn't conduct a barrier assessment to see if there were scheduling conflicts or transportation issues.
No data at all.
He completely bypassed the scientific method. He substituted an evidence-based tool, the barrier assessment, with a mental heuristic. He used a stereotype because relying on a stereotype requires zero response effort.
Right.
Whereas conducting a barrier assessment takes actual work.
Precisely. Behaviorally speaking, his bias acted as an establishing operation that made the effort of providing those hours seem overly punishing, so he just cut them.
Just unilaterally cut them.
And in doing so, he slams directly into Code 1.08, non-discrimination. The code explicitly states that behavior analysts do not discriminate on the basis of socioeconomic status. Landon unilaterally altered the dosage of a medical necessity based entirely on a private, unmeasured assumption.
It is the ultimate betrayal of the science. His lack of self-awareness didn't just stay in his head as a private thought, it manifested as unequal substandard care.
Which is exactly why the BACB takes this so seriously. Managing bias isn't about political correctness or feeling good about yourself. It is about protecting the client's fundamental right to effective treatment.
Yeah.
If your lens is smudged, your intervention is compromised.
But Landon's case is a very clear-cut example of discriminatory bias. The guy was just using lazy, harmful stereotypes. The sources, however, show us that sometimes what looks like a bias is actually much more complicated.
It really can be.
Sometimes it isn't a stereotype at all. It is a conditioned trauma response.
Yes, the intersection of personal bias and personal trauma is an incredibly delicate area in our field. Case 1.0a from the workbook highlights this distinction perfectly.
Right, so we have a BCBA who is overseeing a supervisee. The supervisee comes to her supervisor and explicitly asks to be removed from a specific case. Why? Because the family dynamic they're observing in the home vividly reminds the supervisee of her own severe family trauma. The supervisor notices that the supervisee is beginning to express negative, almost resentful feelings toward the client's parent.
Which is concerning.
Very. But the clinic director wants the supervisor to help the supervisee, quote, work through her personal bias while remaining on the case.
This is where we have to pause. If we connect this to the bigger picture of behavioral science, we have to draw a hard line between a bias like Landon's unfounded, low-effort stereotype and a conditioning history that has produced a traumatic reaction.
Absolutely.
The supervisee in this case isn't just making a lazy assumption about the parent. She is experiencing a deeply ingrained emotional and behavioral response to specific environmental stimuli that mirror her past trauma.
Meaning the client's home environment has basically become a conditioned aversive stimulus for the supervisee.
Exactly.
And if she is forced to stay on that case, what happens behaviorally? She is going to start engaging in escape and avoidance behaviors. She might start cutting sessions short.
Or providing vague or unhelpful feedback to the parent just to get out the door faster.
Yeah, or subtly punishing the parent's attempts to communicate.
Exactly. Forcing her to tough it out and work through her trauma while on the clock isn't just a bad idea. It is a profound ethical violation.
It really is.
The most ethical move here, to prevent harm to both the client and the supervisee, is for the supervisor to remove her from the case immediately. The family deserves a practitioner whose behavior is under the stimulus control of the clinical data, not under the control of a trauma response.
And the supervisee deserves to operate in an environment where she isn't constantly exposed to aversive stimuli without support. The workbook notes that ideally the agency would offer her counseling or resources to help process that history.
Right.
But forcing her to stay is just a recipe for clinical failure.
It is. And this brings up a crucial takeaway for you as a practitioner. Ethics Code 1.10 explicitly includes mental or physical health conditions and marital or relationship challenges under the umbrella of personal challenges that might interfere with professional work.
Which means recognizing your own mental health boundaries, admitting that a specific case is triggering your own challenges, and choosing to step away is not a weakness. Not at all. It is not a failure of your ABA skills. It is actually a hallmark of ethical competence. It proves that you value the client's outcomes over your own ego. You are monitoring your own capacity to deliver reinforcement just as rigorously as you monitor your client's behavior.
That is a brilliant way to frame it. But it naturally leads us to the most difficult operational question of this entire deep dive. Since we have established that biases, assumptions, and personal trauma can be devastating to clinical outcomes, how do we actively catch them?
Right. This brings up a really fascinating philosophical paradox based on our sources. Applied behavior analysis is a science entirely devoted to observing and measuring outward objective behavior.
Yep.
We always say, if a dead man can do it, it ain't behavior.
Yeah.
So how on earth do we measure something as internal, private, and invisible as a bias? I can't take frequency data on a prejudice.
It is the ultimate paradox of radical behaviorism. And the ethical workbook acknowledges this exact limitation. Currently, there is no reliable behavioral technology for directly measuring a biased thought in a purely objective, observable way.
Right, it's all internal.
We can observe the results of the bias like we did with Landon's skewed parent training hours, but the bias itself is a private event. Therefore, we cannot easily graph it before it causes harm.
So if we can't measure the private event, we have to externalize it. We have to drag that internal bias out into the verbal community where it can actually be examined.
Exactly. We have to rely on self-monitoring and external frameworks. The text references specific, actionable strategies recommended by the American Academy of Family Physicians to help practitioners evaluate and mitigate their own biases.
Okay, looking at these AAFP strategies, the very first one is exploring your prejudices through peer conversation, which makes total behavioral sense based on what we just discussed.
It really does.
You cannot analyze your own blind spots in a vacuum because your ego will always reinforce your own decisions. You need a trusted colleague, Someone who will look at your caseload, your intervention choices, and your raw data and ask you the hard, uncomfortable questions.
Like, why did you choose this intervention over that one?
Yeah. Or why does your tone change when you talk about this specific mother?
That peer review is the mechanism that translates a private, covert behavior into an overt, verbal behavior that can be analyzed and corrected. It provides an external contingency for your clinical choices.
Exactly.
But peer review usually happens after the fact. What about in the moment?
That's the real challenge. I can't call my colleague every single time I'm about to reply to a frustrating email from a parent or right before I walk into a chaotic home environment.
Which is why the next AAFP strategy is so critical, pausing and reflecting before interacting.
So what does this all mean behaviorally? When you intentionally build in a pause, you are functionally interrupting an automatic behavior chain. You are inserting a temporal delay between the stimulus, like that frustrating email, and your response.
Precisely. When we are frustrated or tired, our behavior is often under the stimulus control of the immediate emotional contingency. We react reflexively.
Right, without thinking.
By inserting that pause, you create a gap. You allow time for your verbal repertoire, your knowledge of the ethics code, your clinical training, your understanding of the client's history to exert rule-governed control over your actions. You let the science override the reflex.
You are giving your prefrontal cortex a second to catch up, and that naturally feeds into the final strategy from the text, which is evaluating people on individual characteristics rather than stereotypes,
Yep.
which really just brings us right back to the foundational core of ABA. We treat individuals, not diagnoses. We treat specific behaviors, not assumptions.
And this is where Code 1.L AMO Managing Bias integrates perfectly with Code 1.07, which is cultural responsiveness. Cultural responsiveness isn't just a corporate buzzword. It is the behavioral antidote to bias.
Oh, I love that.
It is the active, continuous commitment to understanding the unique contingencies, cultural values, and learning histories of the specific family sitting in front of you.
Because if you don't understand the cultural context of a behavior, your intervention is probably going to fail anyway. You can't just drop a generic token economy into a household without doing the work to understand what that family actually values.
Definitely can't.
When you are culturally responsive, you literally cannot rely on stereotypes. You are forced to shift away from low-effort, cookie-cutter programs and design truly individualized, socially valid care.
That is the ultimate goal. When you acknowledge your blind spots, when you build in those temporal delays, and when you invite peer review, you clear the way for genuine, compassionate, and highly effective behavior analysis.
Which is exactly what we set out to uncover today. Let's recap the mission of this deep dive. We learned that the BACB doesn't expect you to be a flawless robot without a learning history. That is the classic exam trap.
Yep.
Biases are structurally inevitable. The ethical mandate is to know them, actively prevent them from impacting your work, and rigorously document your mitigating efforts. We saw how unchecked bias bypasses the scientific method, leading to skewed clinical decisions.
Like Landon using a stereotype instead of a barrier assessment to alter the dosage of his clinical care.
Exactly. We also explored the critical behavioral distinction between a bias and a trauma response. We recognized that stepping away from a triggering case isn't a failure. It is an act of ethical competence that protects the client from your own avoidance behaviors.
And finally, because we can't easily measure bias with a clicker and a clipboard, we have to rely on proactive, documented frameworks. We use peer review to externalize private events, we use pausing to allow rule-governed behavior to override emotional reflexes, and we commit to cultural responsiveness to ensure our interventions are grounded in the reality of the individual, not the convenience of a stereotype.
If we connect this to the bigger picture, well, actually, you usually say it best.
Oh, thanks. If we connect this to the bigger picture, protecting the client doesn't just start with a good functional behavior assessment of their behavior. It starts with rigorously auditing our own. The human instrument taking the data must be calibrated just as carefully as the intervention itself.
Perfectly said. Which leaves us with a final, lingering question for you to mull over as you go about your practice this week. As behavior analysts, we spend our entire careers meticulously taking ABC data on our clients. We look at the antecedents, the behaviors, and the consequences.
Right.
But what happens when you are both the organism behaving and the environment reinforcing that behavior? How do you take accurate ABC data on your own internal biases when the reinforcer is your own ego? Keep questioning, keep learning, and we will catch you on the next deep dive.